6 months ago, the legislature passed House Bill 5, well-intentioned legislation written to address billing disputes that had emerged as Kentucky moved Medicaid to a managed care model. I vetoed House Bill 5 because its language might have interfered with contractual rights between the providers and the managed care organizations. But I agreed on the need for action. So I announced an aggressive, multi-pronged plan to address the billing issues. At the same time, my plan was designed to continue to facilitate the cultural shift needed among both providers and MCOs to make Medicaid managed care a success. I vowed to report back on the progress of my plan, and we're here to do that today. However, let me reiterate a warning I gave 6 months ago. This is a complex topic with many levels of consideration. The issues involved are neither easy to understand nor possible to simplify in a way that does them justice. So if you're here for a soundbite, you're in the wrong place. Today's going to be more of a briefing than a press conference. I'm going to go into detail and cite a lot of numbers and facts because it's important to see the evidence supporting the conclusions that's been reached. So I urge the media, when you go to critics of Medicaid managed care to get their reaction to this press conference, don't be content with sound bites. Don't let them cite an anecdote, spout off with inflammatory rhetoric, or repeat general complaints and walk away. Require that they too open their books and bring out their proof. And then look at both the overarching picture and the evidence that supports it. Because if you do, you'll see that Medicaid managed care is working in the Commonwealth of Kentucky and that it will continue to work. Yes, there were some bumps in the road at the beginning. That was to be expected when you tackle such a huge, long-standing problem like an inefficient health care delivery system that's more expensive than it needs to be. Over the last 2 years in Kentucky, we have forced a sea change of incredible magnitude by moving from a fee-for-service model to a managed care model. That fee-for-service model had been in effect for almost 50 years, since Medicaid was established in 1965. During that time, Kentucky has spent literally hundreds of billions of federal and state taxpayer dollars to improve the health of its most vulnerable citizens. And yet, we continued during all of that time to rank near the bottom of every major health category. Our collective health has not improved in any significant way during all of that time. Folks, one definition of insanity is continuing to do things the same way over and over again and expecting different results. Well, the fee-for-service model was not working, so we changed it. Medicaid managed care is reform with a capital R. Furthermore, many of these bumps weren't really bumps, but roadblocks created by people who liked the old system in which they made more money. If you remember, my plan was designed to force both MCOs and providers to work with us to address complaints that had arisen. So what did that plan entail? The first strategy streamlined and improved the complaint process. I moved the jurisdiction for disputes involving providers and MCOs from the Department of Medicaid Services to the State Department of Insurance. I did this for 2 reasons. One, DOI already had a well-established dispute resolution process in place. And 2, it's how disputes in the private market are handled. We wanted efficiency and consistency. So the Medicaid Prompt Payment Compliance Branch in the DOI's Consumer Protection Division was created April 15. One way that DOI expedited the complaint process was to create a specific complaint form just for Medicaid providers and to make that form available online. So, what's happened? Since taking over the process, DOI has received 1,935 complaints. Some 67% have been closed or almost closed, and they've taken on average about 43 days each to resolve. Of the ones that are closed, about 41% were found to be justified. The rest, 59%, were found to be either unjustified, as in the MCO's position was upheld, or were simple inquiries or are questions of fact and issues that need to be answered by a court. Now, it's interesting to note that most complaints were related not to prompt pay, which is what the hospitals were yelling about, but rather to claim denials, prior authorization disputes, or unsatisfactory settlement offers. Coding errors and credentialing issues continue to pose problems for providers and will require careful monitoring by all involved parties. The bottom line is, complaints are now being resolved promptly. Equally important, the vast majority of the complaints made by providers against the MCOs are very similar to the complaints they make against private insurers, demonstrating that managed care is working just as well as the private marketplace is. Now, the second action we took. The second action was to address complaints that medical providers were not getting paid in a timely fashion. The allegation was that the MCOs were holding back payment, and we heard quite a few stories of enormous accounts receivable figures that, if true, would have been outrageous. So we investigated this. Back in April, I mandated that every MCO meet with every network hospital and any individual provider who requested such a meeting. The purpose was to fully review each provider's accounts receivable records and ensure that each organization was operating from the same set of numbers. Now, most hospitals, not all, but most hospitals agreed to the meetings. The good thing is that while some issues remain, the majority of hospitals which have been willing to engage in a meaningful discussion with the MCOs have resolved their accounts receivable balances. But we're finding out some interesting things about those numbers. You see, the hospitals collectively claimed that they were owed some $346.6 million. That's what they said the MCOs were holding back. But after the MCOs and the hospitals sat down, they agreed that $59 million of that figure had already been paid. They also agreed that $26.5 million in bills had never even been submitted to the MCOs. Bottom line, so far, they've found $7 million in claims that on second look and review, the MCOs decided should have been paid after all. Now, $7 million sounds like a big number, at least until you realize that it is 2% of the $346.6 million that the hospitals claimed they were owed. Why the big discrepancy? Well, the face-to-face meetings found many reasons. One, as I said, a good number of bills had actually never been submitted. In fact, one of the billing vendors used by many of the hospitals had a logistical problem with the process that had caused bills to be hung up. You can't pay what you don't know about and you haven't received yet. Two, some hospitals made a practice of, when they resubmitted a bill whose payment was in dispute, double counted the amount owed. Three, some hospitals listed the full amount of claims as owed even though those claims had been partially paid and there was a smaller amount in dispute. For example, if the MCO had paid $90 of a $100 bill and $10 was left in question, the hospital listed the whole $100 in its accounts receivable. Four, some hospitals are not giving claims time to go through the process before they list them as unpaid accounts receivable. There's at least usually a 30-day lag time. That's normal. Five, many smaller hospitals simply have billing systems that aren't very sophisticated and employees who aren't very experienced. That led to a lot of errors. And six, The biggest reason. The Kentucky Hospital Association and many hospitals continue to use figures that don't remotely reflect what they expect to be paid. They continue to do this even though I called them out on this practice in great detail during the April press conference. You know how this works from your own experiences with the healthcare system. You go get healthcare, you have a procedure done, and you receive a bill for, let's say, $10,000. Well, when you first see that, you get sticker shock. That's quite a surprise. But then you go down the bill and you find that after insurance pays a fraction of the bill and you pay a fraction yourself, the majority of the bill is written off because of contractual rates, because of the rates that the hospitals have agreed to in advance they will accept for that procedure. Well, many of the hospitals continue to use that large initial number in their accounts receivable. Just how misleading is this? Well, it inflates the amount the providers actually expect to receive by about 5 times. We looked at the 4-year period leading up to managed care implementation, from November 1 of 2007 to October 31 of 2011, when the fee-for-service model was still in effect. Now, during that time, and this is under fee-for-service, during that 4-year period, hospitals said they provided $25.75 billion in services. That's what they billed, $25.75 billion. You know what they were paid? $5.2 billion. In other words, they were reimbursed about 20% of billed claims. They know full well they won't get that billed amount. They never have, even before managed care. So for them to continue to use these figures as money they are owed is disingenuous at best and at worst, downright deceptive. Now, put all these things together and you get a wildly inflated bunch of claims that have misled both the public and the legislature about the nature and the scope of this problem. The accounts receivable reconciliation meetings revealed that inflation and brought some truth to these numbers. In your packet, we've listed a few examples showing the huge discrepancy between what some hospitals said they were owed and what they were actually owed once they sat down with the MCOs and reconciled their accounts receivable. In one case, the real number was actually 0.6% of the number that they and the Kentucky Hospital Association had passed on to the media and to the legislature. Again, fortunately, those hospitals that did meet with the MCOs were able to resolve most of their issues. The third part of the action plan announced in April, that was what we call joint targeted market conduct examinations. We didn't take sides in this. We put the MCOs under the microscope too. Each MCO agreed to these exams, which are a type of audit performed by the DOI. The exams specifically reviewed the issues which garnered the most complaints from providers: pre-authorizations, pharmacy, hospice, emergency room, behavioral health, handling of grievances and complaints, and compliance with prompt pay statutes. The goal, as I said in April, was to determine whether systemic changes were needed in any of these areas. The MCOs had to fund the audits. The reviews identified some common concerns, including errors in processing and bill submittal. DOI also reported that the MCOs tended to not explain very well the reasons behind denials, which led to more grievances. Provider coding and billing errors also led to problems, including a backlog of denials due to duplicate billings. And finally, the prior authorization process lacked some consistency. As a result of the targeted market conduct exams, the Department for Medicaid Services sent corrective action plans to 2 of the MCOs, Coventry and WellCare. They will report back on their progress each quarter. But again, it's revealing that the problems found in the joint targeted market conduct exams by DOI are very similar in scope and in rate to the issues typically found by DOI in the private sector with private insurers. In other words, MCOs are conducting themselves in a manner similar to private insurers. The fourth part of my action plan had to do with communication and education. A big problem from the beginning has been that MCOs and providers were simply not talking constructively. So we held 8 Medicaid informational forums around the state. More than 2,300 medical providers attended. It turned out to be some very valuable and helpful FaceTime. Providers not only got to share information and ask questions about general procedures and issues, but also got to meet local MCO representatives for what we call side conferences to talk about specific concerns or problems. Most questions at the forums were driven by contractual issues, but other day-to-day issues were aired and resolved as a result of the face-to-face meetings. The fifth action plan addressed emergency room utilization. Everybody agrees that this is a big problem in Kentucky, where our ERs have been turned into de facto primary care and pediatric care offices used for everything from colds to earaches to back pain. In fact, Kentucky ranks in the top 10 states for inappropriate emergency room use. This is a problem for many reasons. ER care is the most costly health delivery option. Many users don't have insurance. Many ER visits are preventable with proper health management. And the heaviest ER users often suffer from mental disorders that are either undiagnosed or untreated. Kentucky has a large number of so-called super utilizers, patients who use ERs at least 10 times in a 12-month period. Let's look at how our Medicaid population in Kentucky used ERs in 2012, because, folks, these numbers are staggering. 346,416 Medicaid recipients utilized the ER at least once. That is more than double the national average for that population. 4,401 recipients used the ER 10 or more times each in 2012. This is 1% of the users. They account for 10% of the ER cost. 2 recipients visited the ER 121 times each in 2012. 1 recipient visited 30 different ERs in 2012 alone. And finally, total ER expenses for Medicaid recipients exceeded $340 million. My friends, that is a huge problem. No wonder our health care costs are so high. So I directed the faculty and staff at the University of Louisville and the University of Kentucky hospitals to develop a system for ER care that represents best practices around the country. We have a work group that is being led by Dr. Stephanie Mayfield, our Commissioner of the Kentucky Department for Public Health, in collaboration with Dr. John Langfeld, the Kentucky DMS Chief Medical Officer. Other key members include the Governor's Office on Health Information Exchange, the Kentucky Hospital Association, the University of Pikeville, all Medicaid MCOs, 16 additional hospitals, the Kentucky Health Department Association, and the Kentucky Department for Behavioral Health and Developmental and Intellectual Disabilities. Already, most of the work group hospitals have held at least one local meeting to review hospital-specific data and discuss ways to impact ER superutilizers. In addition, Kentucky in July was named as one of the 7 states to participate in the National Governors Association Policy Academy on emergency room utilization, with particular focus on managing superutilizers. This is not something that we will solve overnight. In fact, we consider it a 3 to 5 year process. One thing to keep in mind as you consider the ER issue is the fundamental difference in goals. Many hospitals have long depended on their ERs for revenue. That's a foundation of their business model. The more people using their ER, the better it is for their bottom lines. You see that in advertising on their websites where they cite the wait time in their ERs as the reason you should seek health care at that hospital. But on a public policy level, our goal is to keep people out of the ERs. In fact, our goal is to keep them so healthy that they don't ever need intensive health care. And when they do need it, we want them to seek it in the most appropriate setting. That difference in goals presents a challenge to many hospitals, and they're going to have to change their business models to match the public policy goals of the Commonwealth of Kentucky. Now finally, action plan number 6, making sure that the MCOs are adhering to what's called prompt pay standards. You've heard a lot about this issue, and there is a lot of confusion and misperception about it. So first, let's define it, because a denied claim is not a prompt pay issue. Under the prompt pay law, insurers and MCOs can be penalized if they don't meet 2 thresholds. 1, 95% of clean claims. That is defined as those submitted properly and with complete information. 95% of clean claims must be adjudicated within 30 days. That means approved for payment, denied, or contested. Number 2, of those clean claims that are approved for payment, 90% of the dollar amount must be paid within 30 days. This mirrors the standards for the private insurance market. It also creates a learning curve for providers because they were used to operating under the old Medicaid standards, which was a 7-day period. So they've had to learn to manage their cash flow a little more closely. Now, initially, MCOs were self-reporting these numbers. But because DOI believed more scrutiny was necessary, it began acquiring raw claims data in order to determine whether the MCOs were truly meeting the standard rates of prompt payment. What DOI found is that prompt pay is not the problem that some providers say it is. There is not a deliberate effort by MCOs to withhold money on a routine basis, nor is the system set up that way. Now, that doesn't mean that there can't be improvement or that there shouldn't be improvement. Since DOI began looking at the raw data, all of the MCOs were found to have met the prompt pay standards except one, Coventry Cares. Coventry Cares failed to meet the 90% threshold for approved claims paid within 30 days. DOI has proposed a fine for this failure during the first quarter of 2013 and is requesting a corrective action plan. But Coventry was the only MCO found to be in violation of the prompt pay law. So again, the facts show that the prompt pay problem isn't as bad as critics say it is. But the MCOs know that we're watching closely. The bottom line is that we are delivering on the twofold promise of managed care. One, we're creating better health outcomes for our people. And 2, we're saving taxpayer money while doing it. 2 years is a short window to look for meaningful health improvements because this is a long process of not only changing health attitudes, but also changing health practices. However, we're seeing some very encouraging signs that providers, MCOs, and patients are collaborating to create better health habits that will lead to long-term good health for Kentuckians. Among the improvements, and these are compared to statistics before managed care, a 93% increase in smoking cessation consultations, a 33% increase in flu vaccines for children, a 14% increase in HPV vaccines, a 4,655% increase in 12-lead electrocardiograms, which is screening for heart problems, a 4,538% increase in mammograms, a 17% decrease in amputations, which often are a result of untreated diabetes, and a nearly 11% decrease in CT scans. Now, as far as cheaper cost, when the state implemented managed care in November of 2011, budget analysts anticipated that by using contracted MCO rates, the state expected savings of $1.3 billion over the biennium. To date, Kentucky is still on target to meet that savings amount. Of that $1.3 billion, $390 million is state money. The rest is the federal Medicaid match. Costs per patient have remained below forecasted amounts, and new enrollment is flat or declining, which adds to the anticipated savings. Now, one final thing to put all of this into perspective. Some people say these bumps in the road happened because Kentucky tried to implement Medicaid managed care quickly. That's partially true. We did do it quickly. Why? Because we had to. Go back and look at your history and remember what happened. We were facing a significant hole in the Medicaid budget, some $142.4 million. Why? Because financial help from Congress in the fall of 2010 came in much less than the General Assembly had anticipated in writing the 2011-2012 biennial budget. We had a $142 million hole, and our options were limited. We could, number one, cut provider rates by 30% and or cut some $600 million in health care services in a 6-month period, guaranteeing a whole lot of suffering for Kentuckians. Or we could shift some money from year 2 of the biennium to stabilize year 1 and reap long-term savings by implementing managed care, which, by the way, some 47 other states have already done. But we had to act fast because we had to get the budget balanced. Those were our 2 choices, and I'm not going to apologize for making the right choice. We knew there would be bumps in the road, and there have been some. But many of these bumps, as I've already said, came because of reluctance on the part of some providers to adapt to the new, modern Medicaid system. As today's presentation shows, in those cases where the process had flaws, we have moved to correct those and will continue to do that. Medicaid managed care is here to stay in the Commonwealth of Kentucky. It's slowly improving the health of our people, and it's saving us money in both the short and the long term. With some improved cooperation, its operation will be smoother and its benefits will be greater. Thank you very much, and now we will take questions, and I have the people up here who can answer it.
When Kentucky moved 560,000 Medicaid patients into managed care November 2011, so how many Medicaid patients does the state have now?
You're talking about not counting the new expansion that we're doing. Is that what you're trying to compare
How
to?
many are in managed care today?
825,000 ballpark total Medicaid, 700,000 are in managed care, and the difference between the 560 and the 700,000 was Region 3, which is Louisville, and they were in passports. They were already technically in managed care. It was just a different kind of waiver.
Okay, so about 700,000 total in managed care
Today,
now.
correct.
Okay.
So there's 125,000 that are not in managed care?
That's correct.
Give them an explanation of what that is.
So those, what's not included in managed care are all of our waiver programs, which is basically like Michelle P. acquired brain injury, short-term and long-term, support for community living, and the biggest portion of it is in cost-wise, not in people, but in cost, are the nursing homes, the long-term care recipients.
Do you foresee any need for any legislation in the 2014 General Assembly regarding managed care, or do you feel like you're all on the right track? And
We're going to be reviewing our statutes and our regulations to see if we need to make any tweaks, but in the main, this system is working. It continues to work better every day, that we have time passing, that providers get more educated about how to handle this system. That's been one of the biggest problems, obviously, is that they were used to doing what they want, sending us the bill, and we would write them a check. It was that simple. And we've changed all of that. They are now having to deal with their managed care organizations in Medicare the same way that they've always dealt with private providers. With private insurance companies for insurance policies that cover things that they do.
Governor, there's still a lot of providers and a lot of advocates who disagree with what you presented. They say nothing has changed. Why do you think their interpretation is so different from yours?
You'll have to ask them. We've given you the facts and figures of what's going on. We've given you the improved health outcomes that we're seeing every day. I'm sure there's a provider out there someplace that has an anecdote about, I didn't get this bill paid correctly, or this went wrong, or that went wrong. Well, you can have the same example in the private insurance market. But looking at this as a system and looking at it overall, this system is working. It's working. People are getting the care they need, and we are saving money, both short-term and long-term. The emphasis has shifted. It has shifted to wellness. It's shifted to prevention. And that's what managing the care of a patient is all about, is keeping them well, teaching them how to handle their condition, whether that's diabetes or whether that's a heart condition, so that they don't have to go to the emergency room. In a lot of our areas, as we mentioned, folks in the past, they got a headache, they went to the emergency room. If they had a stomach ache, they went to the emergency room. And look at some of this overutilization of emergency rooms. That's where millions of dollars was flying out the door. Managed care changes all of that, because everybody ends up with a primary care physician and a person that manages their care. And that's where they need to go. Obviously, if it's an emergency, it's another thing. But so many things that used to be paid for in an emergency room were not emergencies. And a lot of tests and things that went on in emergency rooms ended up not being needed. And so that's a big part of what is changing today. And it's a difficult change. As I mentioned, many hospitals traditionally had their business model built around the revenue they could make off of their emergency room. And I'm not condemning them for that. That was just the business model that worked for them. Well, all of that's changed, because our whole effort here, in order to better manage care and to save money, is to keep people out of emergency rooms, to keep them well, and to teach them how to take care of themselves so that they never end up in the emergency room. And those hospitals are going to have to revise their business model and figure another way for the revenue to come in to balance their books.
Some of the problem you said earlier was caused by, remember the term, misinformation or whatever, to the public and to legislators. Are you trying to make these data available to the lawmakers so they'll understand and be able to answer those constituents' complaints?
We have periodically been briefing individual legislators, both in the House and Senate, on all of this information that I presented to you today. I think they are developing a much better understanding of the situation, a much better understanding of some of these outrageous numbers that had been thrown around in the prior legislative session. And I think they feel a lot more comfortable now that the system is working and that we are making the right kinds of efforts to improve it and to handle problems when they come up, and that there is no conscious plot on behalf of the MCOs to hold back money from providers when they provide services.
Governor, how confident are you that this system is going to be able to handle the influx of new Medicaid patients with expansion?
We're very confident that it can handle the increased number of Medicaid patients. First of all, that number is going to grow somewhat slowly. We're not going to dump an entire 308,000 people into the system tomorrow. It'll take some time for people to identify that they qualify for Medicaid. And so the system will have time to adjust as we go along. And there'll be plenty of providers and plenty of management ability to handle those people as they enter that system.
What is the timeline for moving those people into the system?
As of October 1, we were able to bring our health benefits exchange up. Now these people are going online, they're calling our toll-free hotline number, they're seeing people in person, our connectors, to determine whether they qualify for Medicaid or whether they need to go look at the individual qualified health plans that they can find on the exchange. We have 640,000 people in this state that are uninsured and uncovered. About 308,000 of those will qualify for Medicaid, and the other 332,000 will get their health coverage through the qualified health plans in the exchange.
So you're saying they're just gonna be coming on board individually for like the next several months, or is there
That's exactly what's happening. Each individual is going online or calling us and saying, hey, here's my income, here's where I live, and those essential things they have to plug in, and then the program tells them, or people can tell them, well, hey, you qualify for Medicaid over here. You're not going to have to pay any premium. Or you qualify, here are the health plans and here's the subsidy that you can get. So go and look at which health plan you like and set it up the way you like it, whether you like a higher premium and lower co-pays and deductibles, or whether you want a lower premium and higher deductibles and co-pays. So it's happening one Kentuckian at a time. We also have had, about 375 small businesses that are in the application process. And what that then requires is once that small business picks its plan, then I think their employees
That's right.
can go on and decide what they want out of the plan or plans that the employer has picked. So it's a process that takes some time, and it will go on for some time. And we're going to keep doing it until hopefully we find every one of those 640,000 people. I don't know if we'll ever reach them all, but I think we'll reach most of them. Anybody else?
That you all have been reporting, the folks who have signed up through Connect, does that include both the folks who signed through Medicaid and private insurance?
Yes.
Are you
Yes.
able to break the numbers out, or?
Roughly, and we're just now kind of knocking them down and trying to make sure, but I think it's roughly 2/3 in Medicaid and 1/3 in the qualified health
Yeah.
plans. Is that right?
But I would just add that there are several thousand people that are in the queue and somewhere along the process of completing their enrollment. And if you kind of look behind those numbers, those are a lot of folks that will be choosing a private insurance plan. So naturally, if I'm qualified for Medicaid, I can.
It happens quicker
It
and easier.
happens quickly.
Yeah.
If I'm choosing a private insurance plan, I may want to shop around a little bit more, think about it, see what my friends are doing, come back to it, talk to an insurance agent. So those seem to take a little bit longer. So it seems like quite several thousand of people that are almost at the end of the enrollment are a lot of the folks that will be on private insurance.
Well, I mean, you already know roughly, I mean, there may be some variation, but it won't be much. You know roughly that more than half qualify for the health insurance.
Right, it's about 50-50.
Yes.
A little less than half for Medicaid, so.
Yeah, it's about 50-50 in
Yeah.
terms of uncovered Kentuckians. Anything else?
Thank you, sir.
Thank you.